So thank you very much for the opportunity to be here. It's good to talk on the work we are doing at FIND. This presentation mainly is about how local information can be used to strengthen the decision on where to place diagnostics in order to make an impact. And we are happy to see that the direct agglutination test is on the current EDA. So that's good news. Next slide, please. Okay, so just very quickly on visceral leishmaniasis, is one of 3 leishmaniasis, and it's globally it's common in Latin America, mostly Eastern Africa, the sub-Indian continent, and part of Asia. But with the success of via elimination in the Indian continent, there's more and more increase on being given to Eastern Africa. So in Eastern Africa, it's mainly caused by Leishmania donovani. There are many challenges to the control of visceral leishmaniasis in Eastern Africa. But one of the main things is the epidemiology, which is not fully understood. There is transmission by vectors. There can be human-to-human transmission, and there are also reservoirs that are there in the communities. And yearly, there are many thousands of cases reported. Another challenge is the performance of the current tools that we have, the RDTs. Performance is not as good as in the endemic areas, which leads us to having a more complex diagnostic algorithm in the region. And basically, it's one of the diseases that's been targeted in the new WHO roadmap for elimination as a public health disease. So in Kenya is one of the top 10 high burden countries in the world, and it reports roughly 1,000 to 1,500 cases every year, although this is believed to be underreported. And the disease is endemic in 8 counties. It used to be 6 counties: Turkana, Marsabit, Isiolo, Wajir, West Pokot, and Baringo. Last year, there was an outbreak in Kittu and Garissa, which have been added. And this year, we're hearing of cases being reported in another county. So the epidemic situation keeps varying from year to year. But the main challenges basically are inadequate access to diagnostics and drugs. There are recurrent outbreaks. The cost to patients and to the health system is huge in taking care of the patients, providing their food, their admissions, the labor. And there's also low disease knowledge by health workers. And this is also made worse by the fact that there's high turnover, so we have to keep training health workers constantly. And there's also low disease knowledge by the local population in terms of seeking healthcare early. And one of the other challenges is the poor use of data to strengthen surveillance. So there have been many reports of VL outbreaks in Kenya, and usually they are sensational in the news, leading WHO and other partners to try and address the situation as best as possible. So our work as FIND mainly is to improve access to diagnostics and eventually treatments. And we use a phased approach. First, there is a need assessment, mapping and identifying the health facilities in the counties, which is followed by the strengthening the laboratories, improving the infrastructure, supporting with equipment where needed. And then there's a training of personnel, both laboratory and case management. And we supplement these activities by community awareness, behavior change communication. And finally, we do monitoring and evaluation. And so basically, we aim to have a network of health facilities that provide diagnosis and treatment in endemic areas, thereby improving the patient's management and welfare. Also, one of the aim is that at the end, we can have a VL access model that can be replicated to other countries within the region. So our activity started in 2016 in Turkana County. And in 2017, we added one more county, Wajir. In 2018, 2 counties were added. Last year, 4 counties were added. So we're currently in all endemic areas, all endemic counties in the county. So at the moment, there's a network of more than 80 health facilities that provide diagnostics to the local communities. At the start of the project, there were 22 facilities that were providing diagnostics, and this was increased by more than 60 facilities through our activities at point. So this is quite significant in terms of making sure access is provided to the population and leaving no one behind. So what I'm going to do next is just take the example of one county, the Marsabit County, and how analyzing the local data can help in deciding the placement of diagnostics and the impacts on other indicators. Marsabit County had 3 epidemics in 2014, 2017, and 2019. And our activities in Marsabit started in 2018. And basically what you see here is the distribution of cases in the 2 epidemics in 2017 and 2019. So basically, by mapping the communities and mapping the health facilities, we are able to trace which communities report to which facilities and how that can be used to improve the decision on placing diagnostics. So what you see here is a network diagram, and on the left you see the situation before 2018. And on the right you see the situation after we added 2 new health facilities. And basically, this shows you that by adding these 2 facilities, we reduce the distance that patient had to travel by from 26 kilometers to 9 kilometers. And for VL cases, that distance reduced from 28 kilometers to 10 kilometers. So this is significant, and this just by adding 2 facilities. But there are other considerations in adding or removing facilities. So for instance, this facility here, Visa, which is here, by adding 2 facilities, its relative impact is reduced. So then we also looked at how best can diagnostics be placed to improve access in terms of travel distance. And these 2 plots show you the distance that patients had to travel to access diagnostics. And basically in this plot, here you see the facilities. The dots represent the communities that access diagnostics in these facilities. And for this first community, for instance, they don't have to travel far to get access to diagnostics. However, making the decision to keep or to remove a facility has to be made with very good care. So if you look in the next plot, you then see that by removing this facility, patients have to travel almost 50 more kilometers to get to the next facility before they could access diagnostics and treatment. And you can see the same for when all the other facilities are removed. So this kind of gives us a sense of which facilities are important in the counties, which facilities need to be strengthened more, and how to address facilities that have relatively less impact. We've also seen by analyzing the data from the various epidemics that there's a shift in the demographics in the age structure. And so from we went back to look at 2014 epidemic compared to 2017 and 2019. And basically we see that in 2014, the population, the cases 0 to 10 years were 35%, but this is gradually increasing. In 2017, it was 47%. In 2019, it's 59%. And we think this is linked to all the supplementary activities, the community education, the behavior change, advocacy that has gone into the work to inform communities about the access to diagnostics. And so we also think the older population gradually gets to know more about the disease, and so learn to better protect themselves. So cases are more and more reported in the lower population. But we also see an increase in cases in the female population in these age groups. There are also the impacts on other indicators. So for instance, by looking at the two different epidemics, you see that between 2017 and 2019, there is a lot more cases that have been reported in this county. And again, we link this to all the community education, the behavior change, leading patients to, and also not just the patient, but also the health facility to know more about the disease, and therefore they are testing more people and therefore diagnosing more people. But despite the increase in the number of cases that is observed, you can clearly see that the mean patient delay, that's the time from onset of symptom to treatment, is gradually reducing. And in 2017, it was 47.9 days. In 2019, it is 21 days. So this is a positive impact in terms of patients seeking early diagnosis and therefore getting early treatment. So beyond diagnosis, there are other benefits to the health system. By contributing to the control of VL in Kenya. Currently, the current death rate is at 1.8%. And according to the new WHO NTD roadmap, this needs to be brought to less than 1% for the country to be considered as having eliminated VL as a disease of public health. So if we keep working at the rate we're going at, we believe this is achievable in the next couple of years, but it will require a lot more effort from all the partners. This presentation also shows that optimal placement of diagnosis reduces the distance to patients and therefore the costs to the patient. They don't have to travel farther. They can easily access diagnostics in the closest facilities. But there's the need for local data to strengthen the interventions, and analyzing individual county information could help in targeting activities and resources where they are most needed. There are also impacts at different levels. There's impact to the health system. The diagnostic capacities of the health centers are being strengthened, and the access to treatment in the endemic communities is being reinforced. The health of the local population is being improved, and by bringing diagnosis closer and improving behavior change communication, we are reducing the costs associated to illness, and also making an impact to VL control. Early diagnosis leads to early treatment, which leads to reduced risk of transmission, and thereby we are also improving the coordination with the partners, the other partners in the country, which is very critical. There are so many challenges, and there's the need for a horizontal, vertical, to look at changing from a vertical to a horizontal approach to targeting activities. But this my final slide. There are also some challenges to be considered. One of the challenges is poor adherence to VL diagnostics algorithm. And because of all the education, there are more and more people being tested, and the diagnostic algorithm is not being strictly followed. So this is resulting in a lot more patients being tested negative. And the tests are currently expensive with global supply shortfalls. So we need to strengthen the diagnostic algorithm, making sure that clinical suspicion is strong, making sure that other diseases in the endemic areas that may mimic VL are ruled out first before going on to diagnose patients. And we also see late health-seeking behavior in the population, which sometimes results in delayed treatment and therefore fatality. And so this needs to be improved. And finally, there's the need for financial sustainability to support the VL activities. The local counties, they try their best to support the costs to the patients, the feeding, the labor costs, but there's need for support from both the national government and the international funding donors to be able to support the activities. So that's about my presentation. I'd like to thank my colleagues who've been involved in this work and the various partners, there's WHO, the Kenyan MOH, the county MOHs, KEMRI, DNDI. They've been very supportive, Probitas Foundation, ASCEND, and WHO, who have all been very supportive in the activities in Kenya. So thank you very much.